I think as new practitioners, you're going to be surprised at the number of oral infections you see um, in primary care. We're going to focus on three main types today. So the most common oral infection lesions are candida, herpes labialis, and recurrent aphthous stomatitis. And so let's just look at those and break those down. You'll see I'll do that. And this is brief information, but it's important information. Epidemiologically, HSV1 infects up to about 90% of the population, that herpes simplex virus one. Human papillomavirus, HPV, is also found in the oral cavity. And we know certain strains of it are responsible for oral malignancy. Bacterial infection of the mouth cause periodontitis and gingivitis. And remember, those systemic diseases have been linked to bacterial infections of the mouth, such as cardiovascular disease and diabetes. Candida albicans is the most common oral cavity fungal infection seen. And then aphthous ulcers are shallow, painful, recurrent lesions of oral mucosa. Most common oral lesion in North America, with a prevalence of about 5 to 50%. There are more females affected than males with aphthous ulcers. And then the stomatitis part of it refers to inflammation of the soft tissue in the oral cavity. And remember, that can be induced by chemical or heat injuries, aspirin, food or liquid burns, food substances, hot peppers, spices, gum, oral rinses, or dental products. So the pathogenesis of each one of these that we're looking at, herpes labialis is the herpes simplex virus 1. HPV, the human papillomavirus, invades the mucosal epithelium in the basal layer, and we know that there's about 6 strains now identified for cervical malignancy, and we are certain that HPV strain 16 is responsible for oral malignancy. Gingivitis, bacterial overgrowth in persons with poor hygiene. And I thought this was an interesting fact, in as little as 4 to 5 days without oral care. So you think about our patients in ICU, etc. It wouldn't take very long for gingivitis to start. Candida grows when normal flora is out of balance. So you'll see candida grow with steroid use, antibiotic use. Aphthous ulcers thought to be we really don't know, but we think it's autoimmune in nature, probably provoked by periods of stress. Stomatitis has to do with poor oral hygiene, ill-fitting dentures, smoking, and then other causative factors such as, hot liquids, foods, and different products. Clinical presentation of a person with herpes labialis, HSV1, is they usually come after they've broken out, but there is a prodrome of pain, burning, tingling with erythema, followed by those vesicles, and that evolves into a painful ulcerative ulcers. HPV, generally you're going to see white verrucous, which is a word for warty lesion, individually or in clusters on the lip, the hard palate, or the gingiva. Thrush or candida is a white cottage cheese-like lesion. It's easily removed with a swab, but it can bleed after you've removed it. Gingivitis, areas of inflammation with possible ulceration. It bleeds from hard foods or dental care, is a tip-off. And then aphthous ulcers are pain, shallow, gray-yellow ulcers, single or in groups, last about 10 to 14 days. But there are 3 categories, minor, major, and herpetic. So, when we're physically examining someone, you have to know the difference between your HSV1, your HPV, your candida, gingivitis, and aphthous stomatitis. So the oral lesions are identified by those specific characteristics. Diagnostically, HSV1, usually just clinical presentation. What does it look like? Give me the history. Did you have the prodome? What does the lesions look like? But you can use what they call a Xanax smear, where you unroof one of the lesions and get some of the serum and then send it off. A viral culture, and then serum antibody titers. Interestingly enough, though, I told you in the beginning of this lecture, 90% of the people have been exposed to HSV, but they might not break out with HSV. But we still use those as a diagnostic tool. HPV is by exam. Of course, you could do an excisional biopsy, but really when you see those warty lesions, they're very easily recognizable. Candida, physical exam, but you can look microscopically, looking for that hyphae, but generally it's just a physical exam. Gingivitis by exam. Aphthis by clinical presentation and physical exam again. So it's important for us to recognize. So how do we manage oral infections? Well, it depends on the oral infection. HSV1, really we have options of topical or oral antibiotic, and you'll see acyclovir and valacyclovir. There's other options. And for the purpose of this lecture, you just look at those antivirals. And when it is appropriate to intervene, you also have to consider that you can see some secondary bacterial infection once these vesicles ulcerate. HPV is generally surgical excision, and we're talking oral, for the oral. Candida infections are treated with antifungals. Nystatin is one. It comes in solution, in troches. It works quite well, but it's burdensome or cumbersome to take because if you use the oral, it's usually 100,000 units, 1 to 2 teaspoons, swish, hold, swallow, like 5 times a day for 2 weeks. Gingivitis is treated with oral hygiene, brushing at least twice a day for 2 minutes, using a soft bristle brush, changing those out, and daily flossing. Aphthis ulcers is symptomatic treatment. Some people like topical steroid. I was taught a combination of baby Orajel, liquid Benadryl, and liquid Maalox, and equal parts, shake it, and then apply in the mouth and for symptomatic relief, and it does tend to help. Referrals, really we're looking for severe cases or just cases that don't respond, and you might want to consider an infectious disease physician. Patient education, health promotion, a lot of this has to do with transmission and really prevention, and then intervening and managing correctly. HSV and HPV are spread by contact with the virus, so from kissing to sharing drinks, lip gloss, avoid all activities that expose others. Also, HPV, we do know that it is spread by oral sex. So, really knowing if that sexual partner has a history of HPV, and because the implications at its worst is oral malignancy. Anticipate candida infections is a good patient education health promotion technique, because anyone on long-term antibiotics or steroids, even from using inhalers correctly and then doing oral hygiene to get that inhaled steroid out of the oral cavity. So those are strategies. Daily dental hygiene will prevent gingivitis, not only brushing, but water picks, flossing. And then aphthis ulcers do tend to be recurrent, so if the patient's able to identify the trigger or cause, it might decrease their prevalence of having those very irritating oral lesions. Thank you very much.